some panel information.
Can you start over?
Start over.
Yeah.
So again, welcome this afternoon. We may get started. We may get through the technical glitches, including power failure in Malawi. So this is truly an African panel where you cannot count on everything all the time, either here or there. So anyway, we are glad to have you here. This roundtable is sponsored by AdNA, the Africa Advocacy Forum, which has most of its members of its steering committee and board are in Washington, D.C. Very busy professionals coming from a number of organizations, including Bread for the World, and George Washington University, and a number of faith organizations as well. AdNA has tried since its beginning in the late 1950s, early 60s, with being anti-apartheid. That's where it really gained its name, was on working on sanctions, including Rhodesian chrome sanctions, various kind of divestiture campaigns, and supporting the anti-apartheid movement across the states. And after Mandela's election and the ending of apartheid, AdNA has taken on an Africa-wide focusing on a number of issues. Most recently, we have a Democratic Republic of the Congo working group and a Sudan working group that are trying to deal with the absolute crises there. Currently supporting, by the way, a petition to get the United Arab Emirates to end their support for the rebels in Sudan. And in addition to that, Bonnie Holcomb on my left here, who's really the person who has put this panel together technically and substantively, who is a faculty member in Washington, D.C., and has worked with the chair of our Wellness and Health in Africa Committee, Pauline Muchina from the African Friends Service Committee. And she and Bonnie have really held that group together for several years. So we've been looking at a number of issues of health, but have decided in the current time, while continuing these other working groups I mentioned, to focus upon what we have adopted, as others have, the vaccine apartheid, and how should we address that. We felt it was important to bring it to this association because in the ASA, I must say, we've been very quiet about what's happened to Africa from the cutting of the U.S. aid, not just in vaccines, but also maternal and child health, and in human rights, in democracy work, but especially the one that's having immediate effect with deaths already in Uganda, is the cutting of the aid to support UNICEF and various other NGOs to provide vaccinations. We have had a success in that effort, and that Senators Susan Collins and Lisa Murkowski were able to claw back funds for PEPFAR funding for the HIV medicines, which are desperately needed. With the cutoff of the medicines for the time at the beginning of the rescission, we actually have had pregnant mothers, giving birth to HIV children because the retrovirals that were available had been shipped already, were not used and prior to them. So we're going to dig deep into those issues and come up at the end with what should we in ASA do? What is the call for us to do, and how can we be effective? Welcome. And we'll probably hold our questions for the participants until the end. So Professor Bonnie Holcomb is going to introduce our participants.
Very good. We just lost our connection to the mic. Okay. So thank you, Dave. Thank you for welcome. He's very modest. It was Dave's continuous interest in this issue and pushing for a connection between what AdNA, Advocacy Network for Africa, is doing and what African Studies is capable of doing through its many participating groups. So we put this panel together with people who are extremely well versed in these subjects. We are part of several panels that have presented on this topic at this event, and delighted to see the presenters of really excellent material that we heard earlier in the sessions. So our chair is Dave Wiley. I am moderator and giving just a brief overview introduction, and then we will reorganize the listing so that our panelist in Malawi will be able to speak before the power outage cuts him off completely. I'm an anthropologist and an advocate with a special interest in the Oromo people of Ethiopia, Kenya, and the wider diaspora. I was educated at Bryn Mawr College, Makerere University in Uganda, and Boston University. I've written about the region since '73 and currently affiliated at GW University through the Communitarian Policy Studies group. I'm here in the capacity of member of AdNA, the wellness group, and to moderate the panel. So I'll briefly introduce each of the speakers. I don't want to make it too short because we have a lot of expertise here. And if you know where people have been working and what they've been doing, you can ask questions reflecting that. So Dave has kindly allowed us to move to talking after the introduction, talking directly with Maziko, who is in Malawi. So let me just point out that we're acknowledging that vaccine access across Africa is not merely a public health issue, it's a question of global justice. We're informed in a well-researched article that was recently published in World Scientific News, Achieving Vaccine Equity and Access in Africa, looking at challenges and recommendations, that vaccines themselves have saved 154 million lives in the past 50 years. Dramatically reducing infant mortality, protecting livelihoods, preventing zoonotic diseases from spilling over into human populations. But despite their proven power, these tools have remained inequitably distributed across the world. The most stark evidence of this inequity was revealed during the COVID-19 rollout. Africa, home to nearly a fifth of the global population, had received just 8.3% of COVID vaccines by 2023. So there is this inequity is a form of apartheid, the result of structural, economic, political, and infrastructural injustices. So our panel aspires to address this global condition with the rest of you, some of you who are very well versed in this topic. We panelists agree that these economic and structural barriers revealed during the recent epidemics constitute a system so fundamentally tilted against low and middle income countries and continents that we have titled our panel Ending Vaccine Apartheid. High procurement costs, limited national health budgets, restrictive intellectual property regimes make it nearly impossible for African nations to access, or more relevant to our discussion here, produce cutting-edge vaccines. During the COVID pandemic, wealthier nations reinforced this inequity through vaccine nationalism, stockpiling doses even before they were approved, while African countries waited, often until small supplies of donated vaccines arrived near their expiry date. Such practices violate the principle of equitable allocation based on health need and reflect a deeper moral failure, a global system that values market power over human life. So I have laid out several of these inequities. I think since we got a late start, I would come back to these and address the political and regulatory barriers that compound the crisis, recognizing that high-income countries benefit from robust and well-resourced regulators. African nations face bureaucratic hurdles, dependence on external approvals, limited institutional capacity. Global mechanisms intended to promote fairness, such as COVAX, were hamstrung by funding shortfalls and unequal cooperation among participating states. We'll address some of this. Vaccine equity cannot emerge from systems designed without genuine accountability or shared responsibility. So many of the overlooked injustices, and I really want to focus on this, at least have us keep this in mind as an anthropologist and interested in the community aspects and some of the lessons we have to learn from Africa's treatment of the vaccine, is that vaccine hesitancy in Africa is frequently mischaracterized as hostility, when in fact studies show clear links to other factors: historical neglect, misinformation, and distrust. Communities that have long been marginalized can't be expected to embrace public health interventions imposed from above. Justice requires meaningful engagement, transparency, and culturally grounded communication. So our panelists more fully address these conditions so we can explore paths forward and recommendations with explanations such as African governments' need and challenge to decrease domestic investment, build strong health systems, modernize supply chains, strengthen regulatory capacity. So global partners have an equally vital obligation to support technology transfer, and reform intellectual property regimes, and respect Africa's right to develop its own vaccine manufacturing ecosystem. Local production is not a luxury. It's a prerequisite for resilience, preparedness against future pandemics. So ultimately, vaccine equity in Africa is a human rights imperative, ensuring that every person, regardless of geography or income, can access life-saving vaccines. It's essential for global stability, economic security, and shared humanity. So our position is that justice demands nothing less. In light of these agreements of the people on the panel, let me introduce our first speaker, who is Maziko Matemba, joining us from Malawi. He's a global public health expert and a community and climate health champion. Mr. Matemba has 18 years work and academic experience in the universities of KwaZulu-Natal and Pretoria, Yale, and Kisumu on public health policy, advocacy, and community engagements. He has a wealth of experience in this space. Among others, he's been chairing the National Coalition on Health Financing Advocacy, founding member of a coalition of the CSO Coalition at the Gavi Alliance, and the vice chair of the Malawi Global Fund Coordinating Committee, board chair of Malawi Orthopedic Association, and a champion of the African Union. So he's currently executive director of Health Rights Education Program in Malawi and National Community Health Ambassador. So his topic is Navigating the Tide of Change, U.S. funding disruptions on community access to healthcare services. So Maziko, we welcome you, and we're glad you're still connected to us. And we look forward to what you have to tell us about this topic of the funding disruptions and the impact that that's had in Malawi as a case study. Thank you very much.
Turn it off. Please unmute.
Can they hear me?
Maziko, I think you are
One
muted.
moment.
Hello, you can hear me?
Yes, can hear you
Hello?
now. Yes, go ahead.
Thank you so much, Bonnie and David and everyone for joining. Sorry that we'll not be able to see me because of the
We
power
had you on a
cuts.
speaker in the room, and that connection has been disrupted.
Can you hear me?
We want to be able to hear you here in the room as well.
Hello?
Yeah.
Bonnie? Hello?
We can hear you.
We can hear you. They're trying to connect you to the speaker in the room, the last speaker, the
It was
mic.
working earlier when we tested it. That's
Yeah,
interesting.
we can hear you well and clear, and we could see you as well. Your camera was okay.
Yeah, I'm gonna just double check the volume on here to make sure.
Maziko, are you able to stay on camera? Sorry. Okay, let's see.
Checking our connections.
Okay.
Okay.
There we go.
Okay.
Oh.
Success.
It might be him actually.
No,
We could hear him earlier.
yeah, we
Okay.
could. His mic is on. He should be.
Maziko, we can hear you in the room now, if you're able to present.
I don't think that's him.
Oh, we're
Yeah.
hearing Albert.
We're hearing Albert. I think it might be. Yeah, I think it may be Mizigo's mic.
We did.
No,
hear him.
his mic is working. We can hear him. We heard him briefly. Check your end.
We cannot hear him on our end.
Neither can we.
Right. That's what I'm saying. I'm thinking maybe
Oh.
he is.
But give it another try, Maziko. We could hear you before that. Let me see. Mute and unmute. Ask you to unmute.
Hello, you can hear me?
Okay,
Yes,
we can hear you now.
Perfect.
Yeah, thank you so much. Thank you very much. Sorry for that communication interruption. Thank you so much, Bonnie, David, and everyone, and for allowing me to share our experiences, Malawian experience, on the important topic on vaccine apathy, and most of the low-income countries, which has been also my passion. But because of my presentation this evening in Malawi, I know that in the US in the afternoon, I'll share with you our aspects and also what the US freezing of support to Malawi and other countries has negatively affected the implementation of many health programs. Thank you so much. I think you're able to share my background. I've been working in this space for 18 years plus, in most in Malawi, but also outside Malawi. So the impact of Malawi health gains is at risk at the moment, with USG support being essential to Malawi health progress over the past decades. And just to share a little bit about Malawi, Malawi population is around 22.2 million as of 2025 this year. And our land size around 118,494 square kilometers. And Malawi is Malawi funding for the health sector. 60% comes from the development partners, and the U.S. government is one of the major funder for the Malawi healthcare system for some time now. And 40% comes from domestic resources, including out of pocket and also private sector contributions. According to the current budget, the health budget is around 9.2% of the total national budget. As you're aware that World Health Organization per capita at the minimum for low-income countries like Malawi is supposed to be at $86, but Malawi, we are hovering around $36 per capita. Malawi HIV prevalence, according to the history which we have at the moment, has reduced from 14% in 2000 and to 8% through strong prevention and treatment programs. And this has been attributed to the US government, more probably. I will share more in more detail. About 901,600 people currently are living with HIV, and there's risk of resurgent if prevention programs are halted, like VVMC, PrEP, and SRH. At the moment, because of the halting of the program from the US government, some of those programs are at risk. And withdrawal of US support threatens Malawi progress towards achieving the UNAIDS 95-95 targets. Leading causes of diaries in Malawi, maternal and neonatal is at 13%, is the highest, seconded by HIV and STIs at 12%. Respiratory infections and TB is 11%, and malaria and disease at 7%, and also enteric infections, disease caused by contamination, is at 7%. So this is just the 5 top most leading causes of diaries in Malawi. The broader health system risks Malawi. The fertility rate declined from 6 to 3.7 from 2020-24. This is due to family planning support, and the US government has been one of the major. Termination of funding may increase unwanted pregnancies and population growth in the coming years. Indeed, the trend continues as happened this year. Maternal mortality have dropped from 675 to 381 per 100,000 live births, and neonatal mortality from 44 to 19 per 1,000 live births. And cuts to reproductive, maternal, newborn, and child rape services may severely reverse these gains because US government also funding some of those programs. Area data, viral load and HIV testing declines already show service disruption and emerging health risks. So these are some of the things emerging which you are seeing at the moment because of cutting of the US aid. And the overall USG health funding 2025 for Malawi, the total US government allocation for Malawi in 2025 is US 219 million, of which USAID was around 135 million and PEFA was around 84.1 million. Funding withdrawn after stop order was US 64.6 million, with USAID cutting at 61.6 million, and 42% of its support, and PEFA cutting was around at 1.1 million, that 1% of its support. And the equivalent losses included 8% of 2022 total health expenditure and 31.5% of government health expenditure. So you can see now the significant of US funding towards Malawi's health sector, more especially on reproductive, maternal, newborn, child health, but also HIV and AIDS. The impact of health programs, just to continue, just to share with you more detail. Most supported programs 2025, including HIV and AIDS, with the 148.0 US dollars, and reproductive, maternal, newborn, and child health with around 25.7 million. Most affected programs was reproductive, maternal, newborn, and child health, which I believe immunization programs is part of such. As you're aware that vaccine preventable diseases, they're also part of reproductive, maternal, newborn, and child health, which I think alongside the bilateral and multilateral contribution, this government is one of the key funder for these programs, which lost about 22.9 million of its USAID allocation. The Malawi Extended Program for Immunization, EPI, was supposed to launch the new vaccine, which was halted, most especially hepatitis B vaccine at birth. As you are aware, that WHO has been advocating that the hepatitis B vaccine need to be given at birth than at 6 weeks, because it has shown that it's more efficient, because most of our health workers, but also most of our babies sometimes are born with this condition. So it's better to have prevention at that level. So it was halted because Gavi could not secure support for Malawi. And you know that US government has been a bilateral but also multilateral supporter to Gavi Alliance, more especially the global health initiatives, including the Global Fund and even the Global Financing Facility, the GFF, under the World Bank. Key losses included family planning commodities worth about 2.5 million US dollars. Reproductive, maternal, newborn, and child services losses, some of the resources which was halted, some of the resources about 8.3 million. Sanitation programs have been affected with around 3.6 million. HIV and AIDS program lost about 17.5 million, mainly preventable services, voluntary male circumcisions, PrEP, and also SRH. Other programs including TB, malaria, nutrition, COVID-19, and WASH jointly lost about 22.2 million US dollars. The impact on implementing partners, the total programs terminated in Malawi is around USG 62.7 million. Top partners affected, as you know that Malawi government implement most of the health program through partners. We have Palladium International, around 10 million. that is on health policy and financing reforms. Family health services, around 8.2 million, HIV, malaria, and SRH outreach. Amref Africa, around US 7.9 million, that is community health and workforce training. Chemonics, around 4.1 million, that's health systems and supply chain support. And also numerous local NGOs and councils lost funding for service delivery through the cuts. And going still on the impact, because I believe this is also important in this conversation. Human resource for health, over 4,000 donor-funded staff were affected, were suspended, includes 450 HIV and AIDS experts, 1,800 HDAs, but also 1.9 treatment supporters. They were also halted. Resulted in reduced testing, heavier workloads, and also limited PrEP access. On diagnosis, disruption in sample transportation and viral processing, causing delays in diagnosis and treatment. And information management systems like EMR and IRIMR and OpenRMS experience shutdown, lead to data delays and quality issues in health reporting. Just to quantify impacts on HIV services more, viral load monitoring, weekly samples dropped by 75% within 9 weeks of the freeze. In high-end districts like Lilongwe, Blantyre, and Cholo, decline exceeds about 60%. HIV testing fell by 28% from 317,118 in January 2025 to 229,413 in February 2025. And partial recovery in March 2025, around 265,445 tests, still 17% below pre-freeze levels. Overall impact, immediate disruption of HIV prevention and treatment services, and this risks reversing the health gains and weakening the system resilience. Key actions and recommendations from the study, which we followed through and also we conducted jointly with the Ministry of Health and Malawi Comes College of Health Sciences, and also as a think tank, because I'm also a member of Malawi Health Tank, is a think tank of health professionals and advocates. One of the key actions which we are recommending now, I hope that ASA and team, Bonnie, David, and the team, is engage alternative partners seeking support from the UN agencies, global health initiatives, and bilateral frameworks to sustain terminated programs, accelerate domestic financing reforms, fast-tracking implementation of National Health Financing Strategy and Health Strategy Plan 3 to boost domestic resource mobilization, and also aim to double per capita expenditure by 2030, and provide contiguous funding. And we are lobbying, and also we are also advocating with the Ministry of Finance to allocate emergency funding to maintain essential health services and ensure continuity while recovering partner negotiation proceeds. So we still need resources from the global health north, because at the moment, with the way disruption was done, Malawi cannot pick up. As you see that 60% of our resources are coming from the global north, and the US government has been one of the key funder or supporter to our healthcare system. Allow me to share briefly on the impact on other organizations. We did another study when I was preparing for this meeting with the HENET. HENET is a Kenya-based organization. We did an own study just to get information from other organizations, how they've been affected by disruption of the US government, which other countries are also falling through. So in terms of the landscape, this analysis on the other organization, we had about 15 respondents from across 15 countries, representing a diverse ecosystem of civil society actors working at the front line of development and social change. And we had about 57% of CSOs and NGOs, that traditional civil society in almost 12 countries. And also we had about 29% of youth-led organization led by young people, and also 14% responded from faith-based or religious institutions. the disruption crisis and widespread impact. According to the survey we did, 86% of national ODA disruption confirmed disruption at country level, affecting the broader funding ecosystem, and a 93% direct organizational impact. That is the organization reporting direct effect on their operations and programs. And the data I'm presenting reviews a crisis of unprecedented scope of 86% of respondents confirm that national level overseas development assistance disruption, with an even higher of 93% reporting directly organizational impact. This nearly universal experience underscores that funding instability is not an isolated phenomenon, but a systematic change reshaping the civil society landscape, including the NGO sector over time. And looking at where the pain hits most, according to the survey we did, the
Maziko, you have
advocacy work.
1 minute remaining.
Thank you. That's been affected: community engagement, service delivery, downsizing, government partnership. We are trying to adapt new donor negotiation, internal austerity, and also the partnership pivot collaborated on as a lifeline. We are exploring other ways on how this can be done. And we had some few voices from the field. Operational paralysis: when funding stops mid-cycle, we had hot programs that affect communities that they depend on those services. And adaptation, innovation, advocacy for reforms, and also the other issues to do with the data, reviewed that national disruption, and also some adaptive responses. And building resilience for the future, key recommendation, policy recommendation, donor pool mechanism, institutional CSO participation, fund sustainability strategies, but also regional learning platforms could be key. And from dependency to resilience, that's what we are trying to preach, after getting from this study. I want to acknowledge the people who have worked on this presentation: the Ministry of Health Malawi and the Campus College of Health Sciences, and the think tank, Health and Rights Education Program where I'm working with, HENET team from Kenya, but also the global and national research responders, which support us in getting the much needed response. Thank you so much. I hope I was edible enough, and I hope I've been heard. Thank you, Bonnie and Tim.
Yes, indeed, Maziko, you were heard. We solved the problems in Malawi more easily than the ones here on this end, so we appreciate. For a while, I was not sure when to switch the slide, so we lagged a bit. And now I see that there's an enormous wealth of recommendation and suggestion that you have here that many people in the audience may be interested. If you're willing and interested to share your slideshow, let us know. And we will
Yes, you can share.
We'll ask for people who are interested to study it more closely now that you have completed the oral presentation. Okay, so
thank you.
Very well. I'm looking for. Do you see us, Albert, in the room?
Not yet. Your camera is still off.
Okay, camera's still off. Zoom. Our tech person has set this up, and she is no longer here. I guess I will. I'll introduce Dave, and then Sadia, and then Peter. We switched our.
Okay.
Very well. We have a volunteer tech person here. There you go. No. See, she set it up differently.
So David's going to be on your camera, I guess.
Dave, well, we're trying to find the camera.
Okay.
Because it was turned off by the you see it there? No, I've got too many things open.
Great, but now we've lost the Zoom. Oh, it's up there. I see. Never mind. Sorry. Got it. Thank you.
That's it. We were looking for it on the screen. Is it on?
So we got you.
So who do we want to see up there?
Us. me, and then Dave. So
Okay.
if you just pin us.
I've got it on pin. Okay. So we see you now, Bonnie. You can go ahead.
Very well.
Okay.
Thank you, then, thank you, and thank you for the collaboration here. Dave Wiley is one of our beloved colleagues, and I just wanted to draw attention to the fact that he has a lot of experience that we are relying on in putting some of these materials together. Professor and former chair of Sociology Department, director of the African Studies Center at Michigan State University, past president of the African Studies Association. He'll be awarded later tonight. We'll be able to recognize him there. We'd like to recognize him as a colleague and as a person who is passionately devoted to Africa and African advocacy. He has a PhD in sociology and religion from Princeton University and Princeton Theological Seminary. And he's been in Africa at the University of Zambia, Durban, Westfield, Southern Rhodesia over the years. He's founded and co-founded a number of Africa-related associations. The full listing you'll probably hear tonight if you go. His topic is Before the Next Pandemic, a call for examining the outsized profits of Big Pharma and a demand for broad sharing of vaccine patents and formula. Thank you, Dave, for taking this on, and we will welcome your comments on this. This is the camera. There we go. Good.
Thank you. Well, thank you all again for coming. I want to talk a little bit about the difficulties that we've run into in trying to get a policy in the World Trade Organization that facilitates the sharing of the patents of the vaccines, as well as the diagnostics and the medical delivery, which has been denied over time. And then I want to suggest, secondly, what are the ways that the African actors, the CDCs, the biolabs there, and others can act in this new environment where they have been denied the funding and the access to the vaccines and their patents that we had hoped for. And finally, I want to turn to what do we do as Africanists in the ASA in order to respond to the needs of our colleagues in Africa who are now under desperate attack in the denial of health support of vaccines and the like, which has saved over the years so many millions of African lives, thanks especially to UNICEF and their delivery year by year of childhood disease, mumps, measles, diphtheria, polio, and the like. The vaccines are a miracle. They're an astonishing gift that our scientists have given to us. And I suspect almost everyone in this room, if not everyone, has actually benefited from that. I know that I certainly have, in spite of remembering the terrors of the typhoid shot in the alcohol-reeking gymnasium of my elementary schools with wailing children and persistent nurses. But at any rate, so we're facing, why did we not get the miracle to be produced in Africa so that the vaccines can be seen as a product of the African labs and the research scientists there? And so the task was put before the World Trade Organization in order to pass a policy that would release the patents, the manufacturing technology and the like to the rest of the world. In fact, it was really kicked off in October 2020 when the proposal was made by India and South Africa for a TRIPS waiver, a temporary waiver to facilitate broader access to COVID-19 vaccines and treatments. We wondered what would happen with that, and we're not very optimistic given the forces that are arrayed against sharing of vaccines and their patents and technologies. But we all thought we had a profile in courage when, to our absolute astonishment, our president, Joe Biden, on May the 5th in 2021, announced that the U.S. would support a waiver to suspend IP rights to patents, copyrights, industrial designs, and trade secrets for COVID-19 related projects until widespread vaccination had been achieved. This seemed almost unbelievable that this had actually occurred, but immediately, of course, what happened? He was attacked by his foreign colleagues from the UK, Germany, and Switzerland, especially, which had big pharma companies that were threatened by this. This issue then dwindled on. Things seemed to take an eon to occur in the World Trade Organization. We go by for years without any action being taken. But suddenly there was action on this front in January and February of 2024, when it seemed that there was going to be a decision made at the World Trade Organization. First of all, we had a letter came from Joe Biden's friend, Chris Coons, senator from Delaware. Chris Coons and 14 other U.S. senators sent this letter in January 24 saying, this waiver would not improve global access to these medicines and would have significant adverse consequences for American manufacturers. I wonder what those significant consequences would be. And on innovation and global competitiveness. And so as along with the letter, we did a little checking, and the 15 senators, including Senator Coons, who signed that letter for Biden to call off the TRIPS dogs, that between those 15 had received more than $3 million of pharma political contributions at an average of $200,000 for each of them. Many of those things delivered shortly before the letter was sent from the Senate to the president. And some of the members of that group that signed it had actually received more than $500,000 from Big Pharma in exchange for their vote, although I'm sure that doesn't appear in the record anywhere. And almost simultaneously, a second letter came from Vern Buchanan, the vice chair of the Ways and Means Committee of the House, signed by 20 Republican members, and they urged Biden that this waiver would undermine U.S. innovations and future pandemic preparedness, would harm domestic manufacturing and biotech competitiveness, would benefit geopolitical rivals like China, Russia, and India by giving them access to U.S. IP, intellectual property, and they called this waiver a massive giveaway and a dangerous proposal. So with these pharma-incited letters from the House and the Senate, we did not hear a response from President Biden or from WTO Representative Kai about what the U.S. was going to ask for. All these letters are not a surprise to us, of course. Some of the most astonishing statistics are the number of registered lobbyists as of this last fall in Washington for pharma, 1,796 registered lobbyists, more than all the lobbyists for the DoD military industries, and have been for years. So with an annual budget of somewhere around $350 million, these lobbyists for decades have been building up the influence of pharma in the U.S. Congress to protect their interest, in spite of the fact that several of their CEOs pledged their hopes and their intention to share our knowledge and our help on the vaccines in the future. In fact, that did not happen. As a result of that, Big Pharma has taken away the money big time in the 23-24 period, about a total of $175 billion of profits. It's not a surprise that we, according to Forbes magazine, we have 9 new billionaires that have come out of the COVID pharma industry, 9 billionaires, and most of them with salaries not less than what Moderna's CEO earns, which is about 18 million a year plus stock options and the like, and the amount that I think the Pfizer CEO also with been reporting as of last year a annual salary of 24 million plus stock options. So we can see that they are most concerned about money in order to support the research for the next round of boosters for all of us. So there is a system here that is not new, and which actually gave the companies the right to keep the patents of the development of the vaccines, even though in multiple reports the U.S. tax dollar that you and I and others paid provided 90 to 98% of the research and development cost of developing the vaccines. There is in the Dole-Ball bill of 1950, it's an amendment to the U.S. patent rights that says that the U.S. government has the right to kick in to the process after the patents have been taken by the pharma companies in order to claim authorship and joint patent rights and even funding in order for other purposes. But in fact, there has been no case where the CDC or any of the other agencies, federal government, have used this effort to go back in to claim the funds and to claim joint authorship. It was actually proposed that that be done for Moderna, and the feds decided not to. Clearly, there have been relationships and possibly even passing of some of those lobbyist funds to people outside of the Congress and as well. And so we have this soft peddling, this backing away from any claim on authorship and the like. So given this failure to get the TRIPS through, what are the alternatives that the African scientists have and governments have in order to try to break through and to do something about gaining vaccines for their populations? The first one is the one that I had at one time hoped that we might be able to suggest, which is our going to the are using the usual techniques that we used in the anti-apartheid movement to go to the congressmen in order to get them to change their votes. But I think that that suggestion that we can support the African developers of the vaccines in the governments and the labs there is not hopeful. That the wall has been built so high with the contributions that we are not going to get a turnaround by simply calling on good ethics and goodwill and care for all humanity as a basis for changing the funding flow and for giving access to the vaccines that are needed here. There is one little exception where I think that we might consider actually doing a congressional campaign, and that is that, as some of you probably know, Senator Susan Collins and Senator Lisa Murkowski clawed back money for the PEPFAR program from the rescissions package that Trump was urging on the Congress. They were supported by several other senators within their within the Foreign Relations Committee. And so that was agreed to from the White House that the money could be put back into the PEPFAR program. But in fact, what Secretary of State Rubio has seen happen is that rather than the $4 billion a year that has been the basis of the PEPFAR program in Africa against HIV, they've only put forward 2.6 billion. So it seems to me that now that we have identified a circle of friends in the Congress who were concerned about African health and joined in support of this initiative by Collins and Murkowski, that we might go back to those two senators and say, don't allow them to cut in half the PEPFAR program in the alleged restoration that's going on. In fact, the second thing that African manufacturers can do and participate is through technology transfer agreements rather than owning the core patents, which seems impossible now. It's all going to be really tested because we have these wonderful new malaria breakthroughs in the vaccines at GlaxoSmithKline, Oxford University, Novavax, and so on. And they actually have been willing thus far to cooperate with the Serum Institute of India and with the new BioVac station in South Africa and the Institut Pasteur de Dakar in Senegal, where they are at least supporting licensed production. So that is something to continue on as well. The third one that they can do is a legal process so that some of the aid that we should give to our African partners is people who understand global patent law, because there is a compulsory licensing process, a very complicated process under certain conditions, which when there is an epidemic or a pandemic of danger to a nation, can actually be invoked for a compulsory license to allow local production. But the question is, who's going to produce it? Who will have invested the money to create the labs and the manufacturing facility then, and have the legal status to claim this compulsory licensing? But it is an opportunity that we can use. And some would say it's time to go back to revisit the TRIPS agreement at the World Trade Organization with a new thing called the Doha Declaration. And the Article 31B of the TRIPS says, which allows compulsory licenses in cases of national emergency or extreme urgency. So that's going to be the front that's going to be followed in Africa. And we may live to see another day, maybe under even another administration, when there's hope of going to Congress and getting a turnaround in some of these exorbitant profits. We all know, I think we've heard a couple of the other panels and from Bonnie here, some of the statistics of what all this meant for Africa, that by mid-21, early in the disease, only 1.5% had full 2-dose regimen, and a third Africans had about a 1-dose regimen. So, but toward the end of the epidemic, not even half of the healthcare workers had received 2 full doses. So what can we do now? I want to suggest that we don't know fully how to wage a campaign on this, but that we should look back to the anti-apartheid movement, where we started out, many of us never having paid attention to what the government and the corporations were doing in South Africa, Rhodesia, Angola, and Mozambique. We had to start from the beginning. We had to build a movement. We had to seek the information that none of us had paid attention to. It required the involvement of many of us who were not scientists and were not in this issue at that time. So what I'm suggesting we do, we need to build the information base. We need to be publicists, especially with the faith community, many of which churches have partners in Africa who are being affected by this, and try to drum up campaign for the African diaspora, many of whose families are back suffering the consequences of the lack of the vaccines. and need to build a struggle across the United States in 1,000 ways that we cannot yet support. If you want to see how difficult it is, take a look at the African Activist Apartheid, where you can see the 14,000 documents, pictures, and the like of what it took to build an anti-apartheid movement, when finally it leads to an Anti-Apartheid Act of 1986, the signal that the enemies of humanity in South Africa had given up, and that we moved then toward the freedom of Mandela and others, and the eventual democratic government in South Africa. It's a long way, but we know how to do it out of the previous anti-apartheid movement. So let's talk more about how we get on that horse in order to find alternative ways to support our African partners who will be continuing the struggle in Africa, just as ZAPU, ZANU, and SWAPO, FRELIMO, and ANC did while we were carrying on the anti-apartheid movement here.
Right.
And last, let me just say, it's time for an African voice within the association and from Africanists in our communities. We've been silent for far too long about what has been happening in these racist policies to our African colleagues.
So true. Thank you, Dave. I'm sorry that we got a slow start that requires us to limit our time, but we're very happy to have your observations there. We'll come back to them. Do you want to circulate the edition or circulate the sign-up sheet?
Yes, there's a sheet back here whereby if you'll give us your email
Okay.
and your zip code, we'll send you suggestions of how we're moving ahead with this and some more complete documentation, perhaps even some products from this roundtable as well.
Okay, very good. Our next speaker is Dr. Sadia Ali Adin, who is a medical doctor, a public health specialist, a human rights advocate, and a freelance writer. She's the director and co-founder of the AdNA Foundation, a nonprofit organization based in the United States. Many of Sadia's articles on Somalia and Islam, among others, have been published by media groups around the world. She's a great partner in the kind of effort that Dave has just alluded to. She has been published by Huffington Post, media groups around, Huffington Post, Middle East Online, Islam Online, Global Politician, Al Jazeera, Foreign Policy Forum, Media Monitor Network, Newsblaze, Scoop, World Press, and has been on NPR, BBC, VOA, and Al Jazeera. So her voice amplifies the points that we have reached together, and we are very welcome. We welcome her today. This time, she is addressing us as a clinician, looking at the continent, and her title is A Clinical Review: The Human Cost of Vaccine Apartheid. Thank you, Sadia, for joining us. I hope that the connections work, and we have about 15 minutes for you, and between 12 and 15 minutes, and then we will call upon Peter to speak.
Wonderful. So what I will do is, can you hear me?
Perfectly. Thank you.
All right. So what I will do is I'll try to see if I can share some of my slides here, and let me know if you see it.
Sadia, can you put in your camera? Okay.
Oh, my camera. Where is my camera?
Oh, we see your slides. Thank you.
We see the slides, Sadia.
Okay, so maybe I should leave the slides, or what should I do?
Both would be preferable.
Okay, let me see.
But you could go ahead.
Slides are
Excellent.
more important at this juncture. Yeah.
Am I
Excellent.
there? You fine?
Yes, you
All
got
right.
it. Thank you.
Wonderful. But I need to go back to my slides now, right?
The slides are showing for us.
Okay. Sorry. So are you able to see my slides?
Yes.
Yes.
Okay. Wonderful, wonderful. So you know, it was wonderful really to hear let me, something is cut off from my slides, so let me close them and reopen them. I will unshare them and then go ahead and, sorry about that. Stop sharing.
They were clear on our end in the room.
Yeah, oh, they were?
Yes.
Okay, let me try again. Share. What about now?
Perfect.
Yes.
Okay.
Yes.
All right. So, well, thank you so much, all of you, for all of your efforts. And it was really wonderful to see all of that information, because some of my concerns when I was looking at some of the data was that I was not able to find a lot. So it was wonderful to hear some of the information coming from the ground zero, or rather from the continent. So as we talked about the vaccine apartheid, of course, the way we defined it is systematic inequity in global vaccine access, especially for Africa, where this proportionality of affected during COVID-19 and routine immunization gaps. And the result of that is preventable deaths, long-term disabilities, and structural public health. So some of the childhood vaccines that I wanted to go through those, but then I thought we should just go ahead and first discuss, Africa as a whole, because when we hear routine vaccines, we assume that, like in the United States, the complaint is that we're receiving too many vaccines for our children, where in Africa, not too many, but sort of too few. So the routine childhood vaccines, for example, while Africa has a high vaccine coverage for basic, such as the BCG, which is the TB, polio, and measles, some inequities still exist. Some countries still struggle with the PCG, which you will see on the bottom later, that pneumococcal vaccines, rotavirus vaccines, and meningitis. These are vaccines that save lives, but because they are high cost, they are fewer in a majority of these countries. Newer vaccines usually reach Africa markets years later than they reach the developed countries. This delay usually is due to high prices, limited manufacturing in Africa, because they're all being manufactured outside the continent, and the dependence on Gavi, the Vaccine Alliance, which provides support on complex supply chains. For example, routine immunization gaps in Africa, 12.7 million African children missed greater or less than or equal to one vaccine between 2019 and 2021, and according to UNICEF. And this could be said because of it was during vaccine. But of course, after that, even that gap remains. 8.7 million zero-dose children over some period. Also, that is reported by UNICEF, meaning 8.7 million children have received zero routine vaccine. The main or the routine vaccines, diphtheria, tetanus, or pertussis, coverage dropped from to 72% in 2020. The missed childhood vaccines led to massive measles and polio resurgency. According to WHO, 1.8 million lives saved in Africa by vaccines in 2023 alone. And you can see during the COVID vaccine, many things have fallen between the cracks, and many children were not being vaccinated. Unvaccinated children faced up to 10 times higher risk of death from preventable diseases. Those that zero-dose burden, 28.7 million zero-dose children globally, 2019 to 2022, according to PubMed, NIH, and this is 2024. And I was glad that we were able to find this information, because when I looked at the information that I was hoping the data would be available from USAID, that was not available, and could be because of the discontinued funding or the suspension of these programs. Greater than 80% located in 10 low-income countries, many in Africa. Only 13 of 47 African nations achieved greater or equal to 90% of these routine vaccines. That's only 13 are 47 countries. The progress on recovery efforts. These routine vaccines coverage 72 to 74 from 2020 to 2023. The big catch-up was vaccinating 5 million zero-dose children for WHO. Expansion of messenger RNA vaccine manufacturing in Rwanda, Senegal, and South Africa. Those were ways to catch up on vaccinating these children, or at least improve the future vaccination of the children, African children. These basic vaccines, for example, if we look at the Africa compared to global average, children who received vaccines percentage was 76%, where globally it was 89%. COVID-19 inequity. Less than 2% global COVID-19 doses administered in Africa by April 2021, according to WHO. By end of 2023, Africa at only about 32% coverage, nations ranging from 0.3 to 89 coverage, according to CDC. Another vaccine that's essential, especially for women, young women, is HPV. It's the vaccine. Well, this vaccine is basically used to prevent cervical cancer. So the first HPV vaccine became publicly available in 2006. The first African country to introduce HPV vaccination was Rwanda in 2021. The rest of African countries, it reached 2013 to 2014. And that shows you it's about 7 to almost 8 years delay from when it was introduced. This is just one slide that I put up to see how HPV can be tested. For those who have not had vaccination, the best chance that they have is to do one of these tests. The easiest one to do is the middle one, the Pap smear, which shows abnormal cells. Sorry. So this is just the one slide. And normally the routine one is Pap smear, even for here in the United States, unless there are other issues that providers are very concerned about. So the HPV, that's the name, vaccination coverage remained about 40% in 2023. Africa accounts for about 25% global cervical cancer deaths. Yet the vaccination is very low, even though Africa accounts for 25%. Vaccine access could prevent about 90% or more if it was available throughout the continent. Here again, another comparison. This one is for the HPV. Those vaccinated girls in Africa, 19%, high-income countries, 67%. The COVID-19 is really the deaths are underreported, as we all know, and I think we had this discussion also. Official reports undercounted COVID-19 deaths in some African countries. A study using morgue deaths in Zambia have found that many who died had COVID, but were not identified. And that has been the case not only for Africa, but for many other countries. But of course, Africa, unfortunately, has taken the brunt of the pain as far as this is concerned. Who estimated for global excess mortality 2020-2021 about 14.9 million that were associated from COVID-19 deaths. In Africa, unfortunately, there was a false narrative where that COVID spared the continent, therefore there were not many deaths. And that's being challenged now with some of the information that's coming out. New research suggests infection and death levels were likely much higher than officially reported. During the COVID-19, wealthy nations bought over 70% of vaccine supply, and these could be some of the things that have contributed to the lack of support for the African countries. Many African countries received vaccines months to a year later after the COVID-19 infection broke out or became a pandemic. Some countries had to wait for donations or leftovers close to expiration. And that actually created a problem because by the time they received, these vaccines have expired or were very close, and there was limited time to distribute among the countries that needed vaccines. By mid-2021, Africa had vaccinated less than 2% of this population, while rich countries were giving third booster doses. And this is some of the information that has been found. Low coverage African nations saw highest those who were hospitalized, and mortality surged according to CDC Africa. And there was a delayed vaccine arrival, left health workers unprotected. That's why we have seen, of course, healthcare workers unfortunately have seen very serious crisis because they were not being protected. And though that was widespread across the world, Africa was one of the worst continents that have experienced that. High-income countries vaccinated low-risk groups before Africa vaccinated healthy workers. G20 countries received about 15 times more vaccine doses per capita versus sub-Saharan Africa. 70% of doses delivered to high-income countries during first rollout year were delivered. Underlying structural causes, high-income countries pre-purchased over 70% of global supply, and that's what caused some of the crisis. Limited African manufacturing, which is less than or equal to 1% of vaccines that were produced locally. So always Africa depended on receiving vaccines from overseas, especially from developing countries. There was also weak supply chains, conflict zones, misinformation about the vaccine. Rising pediatric admissions from vaccine-preventable diseases, delayed maternal and HPV vaccination increases long-term cancer burden. The strain on health systems reduces capacity of chronic disease cares. Human cost of low vaccine, more children deaths. Kids died from diseases we already had vaccines for. Unfortunately, even though the vaccines were available, these children were not being vaccinated, and the death toll has increased because they have not made it to the continent. Longer outbreaks. Diseases spread longer in low vaccinated areas. Economic harm. Parents missed work, families lost income, and that has also contributed to the crisis further. Some of the recommendations is policy and global actions that are needed. expand Africa-based vaccine manufacturing hubs, reform global vaccine procurement mechanisms, invest in cold chain surveillance and digital registries, ensure equitable emergent supply allocations. Clinicians or providers, what should they do? They should identify under-immunized patients and communities, strengthen vaccine counseling and culturally tailored education, advocate for equitable policy and system designs. Vaccine apartheid has quantifiable, devastating clinical consequences. Ending it demands a unified stance from clinicians, policymakers, and global health leaders. And these are some of the abbreviations of what I've used in my slides, so just so it will be available. And this is some of the sources that I've used. Thank you so much.
Thank you very much, Sadia. This was really done. It came in on time, and we have. Again, finish. Okay, we have some technical help here to get the screens adjusted. There you are. Hello. Sorry. Has to be done up there. Where are you? There you go. Okay. And it's our great pleasure to welcome Peter Mebardak, a public citizen who has joined us today. He's the director of Access to Medicines Group at Public Citizen, which helps partners worldwide make medicine available and affordable for all. So he has a lot to offer us here. The group's work has shaped laws and executive action in the United States and Latin America, and it has we can say, confidently changed the course of international health and trade negotiations. Peter and his colleagues helped to organize the global movement for COVID vaccine access and have rallied support to expand vaccine manufacturing and technology transfer in developing countries. So this is precisely his area of expertise. Just a little bit about his background. He studied technology at the University of California, Berkeley, anthropology at the College of William and Mary in Virginia. He founded International Professional Partnerships for Sierra Leone, a nonprofit dedicated to supporting public sector development in one of the world's least developed countries. And he facilitates U.S. and global civil society alliances on access to medicine. His commentary appears in the Times, the Washington Post. He sits on the governing board of the Medicines Patent Pool, a United Nations-backed organization that negotiates licenses among drug makers to expand global availability of affordable generics. So he will speak on the topic, Looking Forward to Africa's Vaccine Sovereignty, Challenges and Opportunities. Thank you, Peter, for joining us.
Thanks so much, Bonnie. I think based on what I've heard today from the fantastic presentations from the national level, Masiko talking with us about challenges in Malawi, up to David talking about patent wars at the World Trade Organization, and Sadia, your excellent sort of bridging of the two with vaccine access challenges across the African continent and some of the needed solutions. I think what I can best offer is sort of an effort to get us synthesizing that quite broad range of challenges and how we think about our role in solutions, and then move us into the Q&A. We have a huge amount of work to do collectively, and I think it's useful to recognize something. For all of us who were deeply engaged in the COVID-19 vaccine access fight, I think something we all learned the hard way, if we didn't have it already, is that these are actually complex challenges, and coming at it with one angle, such as trying to improve delivery systems or trying to fight or trying to win the patent war. Like, we can't just do any one of those things and expect the others to line up. And we have to be sort of very thoughtful about how the pieces are going to come together to support a whole, because researching, producing, funding, and delivering vaccines in a way that communities are going to accept and scale up is obviously, there's a lot to do there. I think it's helpful for us to distinguish a little bit between the goals of vaccine coverage and vaccine sovereignty, just in terms of helping think about which piece we want to pick up and how we're going to do it. Because, we've heard some about the coverage problems where we might want to fight Trump's cuts and rebuild in donor nations. The vaccine sovereignty is a little different, where we're talking about actually regionally producing vaccines and getting to scale that way. A few lenses for the problems before us. One is vaccine access during pandemics. The problem that was put on such display in COVID-19 access, it repeated during Mpox. Frankly, I'm going to skip slides just in the interest of time, but we have one on Mpox vaccine access. If you look at the US crisis in Mpox in 2022 and 2023 and compare its timeline and evolution to the same to the most recent crisis across the African continent, the United States was essentially benefiting from having about 400 times as many doses per case available as African countries were. And that shows you sort of the magnitude of the continuing problem in pandemics, trying to get vaccines out quickly when there's an emergency outbreak. But there's a separate problem of routine immunization, as Sadia outlined for us, where you have a widening global gap. We had routine immunization drop because of the global COVID pandemic and because of the diversion of health workers and resources to the fight against COVID. So that's sort of a second lens on the challenge we're trying to overcome. A third is the funding cuts. New to everything since the COVID crisis that we saw is the devastating cuts that David outlined for us earlier, that and Masiko talk about the effects that have really sort of wiped out some of the service delivery systems we'd otherwise relied on and very much hurt national as well as NGO budgets that work in these issues. And how do we rebuild from that? Because even if we had the money, which we don't, it's not as simple as just reinserting into the system and expecting dead programs to come to life. And then, finally, vaccine sovereignty, again, its own lens of not just relying on foreign donation and programming, but actually building up the African sector. Despite those very heady challenges, we have a few developing opportunities. One is those COVID fights David outlined for us, they led to significant normative change. Even while resources are collapsing, global agreement among health practitioners and the agencies that support health and development has really coalesced around a set of values that did not exist in such strength before the pandemic. I'm talking about regional production, for example, which is now a globally shared goal. It's sort of understood by everyone in the health and development and pharmaceuticals game and agreed. If you're not a part of the backlash against vaccines, you're a part of the emerging consensus that agrees we need each part of the world able, capable, resource to produce its own vaccines and diagnostics, and interested in trying to support that change. Something similar goes for technology transfer. This is a really emerging value where we don't want global pharma corporations hoarding not only the doses, but also the means to make those doses. This is something that has to be diversified and shared among producers everywhere. So there's really been a shift in values that can help us quite a bit. There's also regional work for ambition and different initiatives underway on the continent, right? Africa CDC has its goal of 60% vaccine self-sufficiency by 2040. That's an appropriately ambitious and yet at least arguably realistic goal if we really commit to it, to move to that position over time, so that Africa is not just in this position of relying on foreign donations or technology, but has built up its own capabilities. And there have been, some excellent examples of this underway. You see institutions like the Institut Pasteur at Dakar really gathering global attention and partnerships to make vaccines. You had the first mRNA vaccine developed on the continent at Afrigen in South Africa a couple of years ago. The mRNA Technology Transfer Program has partners on every continent and is a South-South cooperation initiative to research vaccines against new disease targets using mRNA, unleash the power of mRNA, and then work on a sustainable marketing solution together. So excellent new ambitious collaboratives. There's the Accra Reset, of course, introduced by the president of Ghana, and the effort of seeing, the development has to be in Africa's hands, particularly in light of the cuts, but of course, as well as just the long legacy of properly anti-colonial politics, we have to find a way to move these initiatives on continent. So with those sort of ideas in mind, what are the prime areas we have to work on in order to achieve vaccine sovereignty? Well, of course, the first one is funding, right? I mean, we need funding solutions, and that's true, internationally, but it's also true nationally with a commitment of greater budgets to both vaccine procurement and coverage and production. And it's not just any one piece of this. If we want real sovereignty, we have to be building up the regulatory structures so that vaccines can be easily approved and moved. We have to be building up the productive capabilities, and then African nations have to be buying African vaccines, which sometimes might mean paying a slight premium, for example, over Indian vaccines. But in order to develop a market for African-made vaccines and regional sovereignty, then we need bodies on the continent that can purchase vaccines from African makers and commit to that. And we need the international donors also prepared to pay a bit of a premium for African vaccines to build up those capabilities over time. There is also the pharma power challenge that Dave mentions, where those of us at least working internationally have to continue to put pressure on pharmaceutical corporations to license the technology that they have and to lower prices, so that in crisis like Mpox, you don't have a situation where really global agencies can have a hard time affording moving those vaccines where they need to be. There's a lot more to say about each of those things, but perhaps I'll try and get us to discussion. But I should also say, well, two things, if I may, before I close. There is also a new chance to fight, and a new something developing right now that I think is very important for our collective awareness, and that is, Trump's new America First global health strategy. They're shopping it around to countries right now, including a number of African countries, and the U.S. State Department is asking for unfettered access to national health databases and pathogen information sharing systems for the next 25 years. In exchange for a very limited partial restoration of the aid that was already flowing last year. It's the sort of proposal, and I can unpack that if it's helpful, but it's the sort of proposal that really undermines the necessary unity and solidarity to have better terms of trade, to have a health system of real benefit sharing instead of just extraction from the global north. And countries are being asked to sign these right now. I hear that Kenya and Uganda may sign these agreements with U.S. Department of State in the next few weeks. And there's a significant question about whether the rest of us can provide enough support and criticism that it's tenable for African countries to reject such inequitable terms and just turning over everything they have to the United States just to get back halfway to last year's status quo when it comes to development aid. It's not good enough. We have to push to do better. So that's a chance to fight right now. I'm keen to talk about, and there's some networks we can help connect folks to that are engaged in this fight. Maybe I can coordinate with Bonnie offline on that as is helpful. Final word just about the politics, right? I mean, what does this take? It takes unity. Obviously, the goal of continental strength and unity is longstanding, and I wouldn't want to paint it as simple. This is obviously complex for good reason, nor is it my place to sort of really try and pick any winners and losers in that. But I will say that the efforts of agencies like Africa CDC to have a continent-wide politics that says, here's how we stand up to pandemics, and here's how we develop our own regional sovereignty. Those are important, right? And sort of initiatives that can help African nations to pool resources and invest in health, invest in procurement and production, as well as vaccine coverage, are all important. So there's that regionally. Nationally, we got to increase commitment. Yeah, we have to fight the power of the pharmaceutical industry, but perhaps right now, even more importantly, we got to fight to restore aid and development funding and a way of thinking about the world that helps lift us all up. A lot of considerations on the table, but that's what I've got for now. Thanks so much for all of your presentations.
It's really a pleasure to have input from all of you on this topic. It is especially good to end with the suggestion from you, Peter, that we have specific actions to take. There have been other panels earlier in this conference that have raised the challenges of where we start with the process of accounting for the development of vaccines. I'm hoping that some of the participants here will speak to that issue. But to have some specific actions is really very good. So it's time for Q&A. We'll take questions from people here in the room responding to these papers. I think we still have all of our participants on the line. And we would also take questions in the chat from those of you who have joined by Zoom. So we can start with this question.
One case that I'm thinking about that I haven't heard anything about yet is the Savin Vaccine Institute, its intervention in Rwanda with experimental candidate vaccines for the Marburg outbreak. There is another Marburg outbreak happening as we speak in Jinka, Ethiopia. I understand it's a different case from childhood immunizations and where the patents might already be expired. But I'd like to hear what your thoughts are on that, on how we might put pressure on the Sabin Vaccine Institute to release more of its kind of vaccine.
Were you able to hear that question online, the speakers?
Yes.
Yeah.
Are there other questions in the room? Yes?
Carl Thompson, and I work with intellectual property rights on seeds. And I have a question of clarity, quick questions of clarity. Definitions really make a difference in how you count. And I was wondering, I'm pretty sure that the vaccines that came from China were not counted. In other words, what is considered a vaccine comes from Moderna or Pfizer.
Mm-hmm.
So that's one question, because I know many in Southern Africa who got a Chinese vaccine for COVID. And then my other question of clarity is, how long is the patent? How long is the intellectual property right? Because we're finding out that they're much longer than seeds should have them. And I'm sure vaccines are dated, what, 2 years later, 3 years later? So what is the intellectual property length of vaccines for that? And then Peter, I very much like your taking opportunities, and Dave, your idea of connecting with Africa diaspora in the US is really important. But I really don't see any point in challenging Big Pharma at this point until we change US capitalism, and I mean that profoundly. Where I see the opportunity that Peter's talking about is South-South cooperation. And as Americans, exposing, yes, what the government and Big Pharma is doing, but facilitate the vaccination capability in South countries, because they are the idea of a regional self-sufficiency. I don't like the word sovereignty, that's ridiculous. Regional self-sufficiency, we as Americans can expose what Big Pharma is doing and then join hands with South countries like India and Brazil who are providing vaccines. And that's exactly what is working in the farmer-managed seed systems and the international movement to protect farmers' seeds. You don't try to change big agriculture in the US. Doesn't matter who we put in Congress, who we put in presidency, including Obama. They're 1,000% for big corporate farming, big food industry. And it's the same with Big Pharma. So I like the diaspora bringing it in, but let's not focus on the US government. Let's focus on joining hands with South-South cooperation. It's something new, different from anti-apartheid.
And you can hear her on screen, correct?
Yep. Mhm.
Okay.
Yep.
Excellent. Excellent.
So the two
Okay.
questions, are Chinese vaccines counted, and how long is the intellectual property right?
And also the comment about the method of operation. Okay, so we have these two specific questions. Any other from the floor? Okay, are there any online?
Yeah, there's one here.
Ah, there's a question here. Okay, we see your hand up, Peter. Do you mind if we take one
Yeah.
question in the room?
Sure, sure.
Go ahead.
Following up on the focus on regional self-sufficiency, Peter, you spoke of perhaps being able to influence our government to financially help production in the South. Is that at all likely politically? Since, you know, foreign aid has always been first and foremost to benefit the country giving it.
Yeah, so I'm happy to take a shot at each of those questions to the extent I can remember them. Very, very good. So let's start with the last one and work my way back. I mean, there's obviously only so much we can do under Trump, right? I mean, Trump is just it's decimated foreign aid. There's not a lot we can do about that, except to fight it and, you know, fight our way to the status quo. As you know, Dave indicated to us at the beginning of his comments, there are places where the regime is sort of vulnerable and will pare back its excesses when opposition raises its head. So when the Republican senator said no to the cuts, you know, we were able to stop some of those cuts. So we have to keep doing that. But in terms of making new affirmative contributions, no, I agree with you. We're not making progress with this government. However, I think it's somewhat underrated how much progress we made in the Biden administration, particularly in the last 2 years, including, yes, funding production in the South, and also paring back Big Pharma's power, and also sharing technology with the global South. Those are all areas where the Biden administration made major commitments in its last 2 years to reduce trade and we were in dialogue with them, you know, to reduce trade pressures on other governments. There is now, and actually the Trump administration has confirmed, okay, let me just give one example that sure says where we are. So the National Institutes of Health are the world's leading funder of biomedical research and development, about $50 billion a year. There's a new policy that was developed over several years, issued under Biden, rescinded briefly, and then recently confirmed under Trump, we understand confirmed by the White House, that says that, and it's now effective as of October 1st. Going forward now, any company that relies on a federal invention, federal technologies, these are like government-owned patents, which includes a lot of the key technology in the NIH Moderna COVID-19 vaccine is actually federal technology. If you're a drug maker or vaccine maker, if you're Moderna and you want to rely on that technology, you want to license it from the federal government, you now have to file an access plan with the National Institutes of Health saying, here's how we are going to support access to this. NIH can turn it down. NIH can work with Moderna to sort of make those policies better. And, you know, it's not as comprehensive as we want it to be. It doesn't have, there's a lot of shortcomings I could outline. But the point is that if that policy, which is now in effect, had been in effect in 2020, the US government would have had quite a bit more leverage to insist on global vaccine equity with Moderna and help save many lives that were ultimately lost. Those are and I could point to several more policies. Those are politics that advanced as a result of all of our advocacy, as a result of the world's experience with vaccine apartheid and inequity during COVID-19. So now we're dealing with the backlash, you know, under Trump and other ways, but this is an example of the kind of normative process that I was pointing to, progress that I was pointing to, where, you know, despite capitalism, despite Trump, despite the power of Big Pharma, you know, Big Pharma is actually taking a lot of losses right now with the US government and internationally in a way that would not have been possible 15 years ago. And some of them really speak to these global equity matters so I do think we should keep working with them internationally. It's also the case that sometimes you get voluntary concessions or negotiated concessions. And that's what I work in on the medicines patent pool, where health bodies are talking to both the generics manufacturers and Big Pharma to say, on what terms can we get generics out to developing countries? And obviously it's not going to be everything that we want, but those are all life-saving improvements on the status quo that can also move the needle of justice as well. On the Marburg candidate, I don't know enough about it. You've got me intrigued, so I'm going to look into it. If it's the case that it is a patented, important vaccine, then there are usually ways we can lean either on the company or on the governments that sort of enshrine the relevant patent rights, either for licensing or for price reductions. Ultimately, yeah, we'd sort of like to have it out there so that others can produce it, either through a negotiated commitment from Sabin and any companies that are involved. And if we push for that, sometimes even if we don't get it or don't get it on the terms we want, we can win price reductions. So that's what happened in Mpox, where the resolution right now is not everything we want, but you have not only the Europe-based Bavarian Nordic producing, but also the Serum Institute in India and maybe others that will produce Mpox vaccines, and price reductions from Bavarian Nordic from arguably from $300 to $65, which is still pretty expensive, but a lot better than it was. So I don't know. I guess the long and short of that is, I agree that for this stuff, I actually do agree that the primary focus really is in Africa, and it's what we can do. It's what African governments can do and what regional organizations will do to stand up change. And then internationally, we have responsibilities to facilitate that. That includes fighting the cuts, but I actually do think there are areas where we can make key inroads that save lives on both pharma and the wealthy governments involved. Thanks. Oh, and someone said the length of the intellectual property. Sorry, a patent is 20 years, but it usually by the time a vaccine comes on market, you're dealing with more like 10 years. Still a long time, right? Especially for things like pandemics, and sometimes the companies stack patents. So it is like for anything that's emerging or technologies that are emerging, patents are just going to be a barrier. And there are ways to work on that and put pressure on it. For the older routine immunizations, if there haven't been significant updates, then often we're talking more about coverage problems, funding health systems, and delivery issues. Thanks.
We have one question in the chat from our online audience. Albie is offering to read that for us.
During the anti-apartheid movement, there was tremendous South-South cooperation, such as the frontline states, the significant financial aid to Southern Africa by Ghana, Nigeria, and more. Also, it was the South, particularly Africa, which pushed international organizations such as the UN to focus on apartheid, and of the African diaspora in the US was significant. Some thoughts and additions.
Thank you, Muiza. Excellent. Well, we have reached 3:15, and I appreciate the participation from the audience, but it was particularly encouraging to see Takashi Tama here, who gave an excellent paper on this topic. He is at Tokyo Women's Christian University and has promised to share some of his work with me. We haven't exchanged yet. But I'd like to highlight the fact that you led a very interesting discussion, and it was quite an inspiring comment that Africans have been involved across the continent in the creation and development through biomaterials over many, many decades, and that bio-sovereignty is something to be considered. It was a very important result of the panel that went before this one. And I think it gives us some way to think about who contributes to these vaccines, not just financially, but also with all of their materials. We have enough, there's a focus that's beginning on that, and I think that's something we can take up. So hopefully we can have a conversation with him and with others who were in that panel, the commentator who will lead us in that creative direction. So thank you, Dave, for inspiring this panel. Do you have any comment on the questions?
No, I just want to add that if you are interested in some of the contents of this program, of this panel, we plan to have it up on the AdNA and perhaps as well the ACAS website in full form. So we will, if we have your name and address on the sign-up sheet here, we will send you the URL to see that if and when you wish it.
As ever, a good organizer. Thank you, Dave. Last year, we had a panel here at ASA in Chicago, lessons learned from COVID-19 pandemic. And that is also up in its full form on the adna/ubuntu.org website. And it was not only lessons learned for the civil society and for the scientists, but what lessons the pharmaceutical companies took away from it. That are interesting to look at in retrospect. So thank you for joining us. Thank you for those online. Thank you particularly for our excellent presenters and for our technician on the Zoom end who was able to hold things together. And we also appreciate those who helped in the room to keep us on track here. A hybrid is always tricky, but this one was particularly tricky.
And Albert.
And his name is Albert Gian. So we thank you, Albert, for your very important role and for your promise to put this together in a way that we will be able to access it later. Is he responding here?
Yes, he's waiting.
Okay, very good. Okay, well, with that, we conclude this panel and we're very pleased at the outcomes. Thank you.
Thank you.